Welcome, and thank you for joining us for our live virtual NDA Engaged Community Education Seminar, where we are highlighting specialists in the South and focusing on pediatrics today. My name is Nicole Petrowski, and I'm the Community Education Specialist for MDA. We appreciate you joining us virtually and are glad to be able to share this important information with you. MDA is committed to community education, and we believe in the power of bringing our community together for opportunities to learn from specialists and having opportunities to connect with others. This event is part of our larger MDA Engage series with disease-specific symposia, community education seminars, and community webinars as well. Our community education seminars, which is what we are having today, are geared towards general neuromuscular disease topics. While each event will feature regional specialists covering these topics, each event will also feature a specialty topic which you can view on the screen. These are the events that we have lined up for the remainder of 2020. And our engaged disease-specific symposiums are geared towards a particular diagnosis, and topics include best practices in care, research, clinical trials, and more. To view agendas for these seminars and symposiums, as well as to register, please visit the MDA Engage section on mda.org. You will also find our past recorded events here as well for your viewing option. We would not be able to put on our educational programs without the support of generous sponsors, so I would like to thank Numotion Foundation, Biogen, and Genentech for supporting this seminar. I would also like to thank their representatives who are in attendance today. Now, I have just a few housekeeping items to go over before we begin our seminar today. We are recording today's event, and we will be posting it to the mda.org website for on-demand viewing in a few weeks, and to ensure those who weren't able to join us live today are able to access this information. For those of you joining the live event, please know that all phone lines have been muted. We will be having a Q&A session at the end of each presentation. So please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A icon to open that feature and enter your question to host. You don't need to wait until the presentation is over either. You can submit questions as they come up. So please feel free to send those in. We also encourage participants to communicate with each other by utilizing the chat feature throughout the day. If you just want to say hi, or to share your story, or to let people know where you're at, you're more than welcome to. Just simply use that chat feature and make sure you click to all panelists and attendees. That way the attendees can see and respond. So type in your comment, so please feel free to use this throughout the day to connect with others. You will also notice on the agenda there are a few small breaks between some speakers, so please feel free to stay connected, go grab a bite to eat or get something to drink. You will hear us speak, just so I can make sure the audio is working for the next speaker. So just know that I am aware of that. And then finally, we will be sending out a brief survey afterwards, and we would like to receive your feedback on what you heard today. We want to make sure we're discussing topics that are of interest to you, and we use your feedback as a way to improve future educational events. So thank you in advance for taking that 5-10 minutes to fill that out. Next, with all those details out of the way, I am pleased to introduce to you Dr. Rosario Maria Riel-Romero, who graduated from the University of the Philippines College of Medicine. She completed internship and general pediatrics residency both at the Philippine General Hospital and at the North Carolina Baptist Hospital Wake Forest School of Medicine. She is the author of numerous peer-reviewed articles and is a professor of neurology and pediatrics at the LSU School of Medicine and is vice chair of the Department of Neurology. She is also the director of child neurology at LSU. So Dr. Romero, thank you for being here with us today. And I will turn the presentation over to you and you can share your screen.
Okay, one moment, Nicole. Hello, everybody. Let me just get my presentation up. One moment here. It was right here. Okay. All right. Okay. Hello, everybody. Thank you for coming on a Saturday morning to join us in this Symposium. I'm Dr. Riel-Romero, and thank you, Nicole, for your kind introduction. I'm presently a professor of neurology and pediatrics here at the Louisiana School of Medicine in Shreveport. I'm very happy and excited to share with you some information about best clinical practices in the management and the treatment and the care of patients, especially pediatric patients with neuromuscular disorders. So just to
Dr. Romero, can you share your presentation?
oh, okay. I'm so sorry.
That's okay.
Okay, hold on a minute. Let me see. Oh, here we go. Okay. Can you see it now?
Perfect. Yes, that's great.
Sorry about that. Thank you. So I was just going to say that the objectives of this talk would be to look at new medications also available for selected neuromuscular disease. Also to look at how we can effectively care for kids with neuromuscular disease during the COVID-19 pandemic. One moment, Nicole. I think we need to go to the other. There's a different presentation that it was embedded here a while ago. One moment, let me open this. Oh, this is the presentation. Can you see this presentation?
Yes, I can. I see the slide. There we go.
Okay, yes, I think this is the correct presentation. I'm sorry. So I would like to describe a typical clinic visit during the pre-COVID pandemic era and during this COVID-19 pandemic, and also describe how we can effectively care for patients with neuromuscular diseases during this COVID-19 pandemic, and very, very briefly touch on the questions we need to ask our healthcare providers and physicians about the newer therapies that are available, just so we are aware of what our choices and options are out there. So during the pre-COVID-19 pandemic, the typical clinic visit is a face-to-face visit with your healthcare provider. And the healthcare providers are usually many, and the MDA clinic is usually a multidisciplinary team. And this team is composed of generally a neurologist, the PMR specialist, together or alone. Also, we have a pediatric cardiologist because they help us assess the well-being of the heart. In many patients with neuromuscular disease, we know that there may be comorbidities and concomitant heart problems that we need to address. Very, very often, we also need the help of the pediatric pulmonologist because a pediatric pulmonologist can help us navigate issues regarding lung functioning and assisting a patient to be able to breathe better without much effort during the course of the disease process. Invaluable in the team is a clinical geneticist or a genetic counselor because, as we know, many genetic diseases have genetic underpinnings or causes. And it is important for us to know what maybe the specific genetic problem is so this can be addressed. And it is also important to know this because many of the therapies we now have available for the treatment of muscle and nerve diseases are genetically based. Physical therapies will help us with the issuance of assistive devices and the teaching and instruction of exercises that can mitigate the weakness and the stiffness that occur often in patients with neuromuscular disease. Social workers can help in issues regarding insurance and other social aspects. In the pre-COVID area, we had an MDA representative, but during the post-COVID era, this has not happened in the recent months because of the risk of transmission and the need for social distancing. Many times we forget nutrition is key in the well-being of children with neuromuscular diseases. Failure to thrive is often a problem, so the help of a nutritionist is vital. In the clinic, in an MDA clinic, we have sometimes special and academic settings, medical students who are also residents and fellows who are higher level trainees and who seek to specialize in a typical field. And in the past, we also had some key or contact persons, especially with the procurement of durable medical equipment, such as wheelchairs, assistive devices like canes and walkers and Hoyer lifts, among others. So this was a typical pre-COVID process in the clinic visit. The typical process when one comes to a clinic visit would be that the doctor will take a history, and this might take a little bit more time. There will be a lot of questions that will be asked. When did it start? How did it progress? Is it worse? It is better? Is it static? Is there a family history? What medications are you taking? The social history, the development of the child are all taken into consideration. So the history of the patient is taken in great detail. And this is also done concomitantly with the review of records. If the patient had been seen by other providers, then the physician will then look at the previous studies that were done, including genetic testing, the EMG, nerve conduction studies, and even muscle biopsies that had been previously done to kind formulate the diagnosis in their minds, and also to try to figure out if this diagnosis really is a reasonable diagnosis, and proceeding from that, formulating a plan of treatment as well. We look at a physical and neurologic examination following the history taking and the review of records. So when we do a physical exam, we look at the patient in total. We look at the face and foremost. We look at the strength of the face, the mouth, the ability of the eyes to move in all different directions. We also look at the tongue, the size of the tongue. We look at the way the tongue moves, if there are any abnormal movements. We also look at the limbs, the extremities or the legs and the arms to see if there are any contractures, whether there's spasticity or whether there is flaccidity of these extremities. And we also evaluate the child as the child is just normally playing, assessing the level of activity and the ease at which the child moves from one place to the other. Neurologically, we'll look at all these different functions like the cranial nerves, again, looking at the muscles, which are very, very important, looking at the strength of the muscles, how big the muscles are, whether they have good bulk. We check the reflexes with a reflex hammer. We check the ability to feel pain and touch and vibration. And in children, sometimes it's very difficult to do a formal exam. So we just watch them play and do an observation of the way they play, how easy it is for them to climb up into the chair, into the bed, into their parents' lap, the way they walk, the way they run after a ball. And after completing all of this in the clinic, we then do a recommendation, which would deal with the diagnosis of, are there any tests that still need to be done to cement this diagnosis? And when we do have a diagnosis, what would be the forthcoming treatment? And also, importantly, the goals of treatment will have to be defined as much as possible. And in older children, especially those approaching young adulthood, the beginning discussions of a transition of care from the pediatric setting to the adult setting should be initiated. And the sooner this is done and the sooner the process is initiated, the better it is when the transition eventually happens. So this is a typical process in the clinic during a pre-COVID typical clinic visit. Blood work. What blood work do we request? We request for muscle enzymes. We check for diabetes because sometimes diabetes, especially if your blood sugar is not controlled, can cause nerve problems as well. Thyroid disease is associated with a lot of muscle disorders, especially Myasthenia Gravis. We check for concomitant rheumatologic or inflammatory disease. Lupus is also associated with a lot of muscle disease. And sometimes we do blood work for genetic diseases because we now know that many muscle and nerve disorders are hereditary, they're heritable. And genetic tests are available to ascertain whether that was inherited, this particular disorder is inherited. And fortunately, these genetic diseases may be, the test may be free and made available at no cost from many companies. So this other financial burden is now offset by this availability. The reason why genetic tests are very important is because we now have therapies that are genetically based, and this all came about when we were able to sequence the human genome in 2001. Francis Collins has spearheaded this human genome project, and with the help of Celera Diagnostics, they were able to do the complete sequencing of the genetic profile of a human being. We know that there are 23 pairs of chromosome in a cell, and each chromosome has many, many genes embedded in it. We now know that in the human body, there are 20,000 to 25,000 genes, and all these genes will comprise 3 billion base pairs or little chemical pairs. And any mutation or any change in any of these base pairs will cause a mutation in the gene that can cause a neuromuscular disease. So just to look at the picture, this is a picture of a karyotype, and these are 23 chromosomes, 22 are autosomes, and 2 are the sex chromosomes, the X and the Y. And each, let me just take this out. And each of the chromosome pair will have a gene. And this gene has many base pairs. Any mutation, a single one in any of those mutations, can cause a disease process, because the mutation can cause the manufacturing or the making of a protein that may be not weak or not maybe functional or only mildly functional, and resulting in muscle disease. So we also do, we will ask for procedures like an electromyogram or a nerve conduction study. And a nerve conduction study just measures how fast an impulse moves through a nerve by using a stimulator to develop a small impulse. We also do a muscle test where we insert the needle, a recording needle, through the skin to the muscle, and we record the activity of the muscle through a machine called the oscilloscope. And that helps us assess the well-being of the muscle as well, and the nerve as well. Generally in children, because a lot of kids may have what we call Duchenne's muscular dystrophy, or and this kind of muscle problems, they may have concomitant heart diseases. So we do a recording of the heart wave tracing to see if there are any problems in the rhythm. And we also try to look at the anatomy of the heart by looking and seeing if there's any enlargement of any of the 4 chambers of the heart. We do what we call an echocardiogram. It's just an ultrasound of the heart. This will help us assess the muscle, the heart muscles as well, because heart muscle is often involved in neuromuscular diseases. And if all fails, especially if the genetic tests do not reveal any forthcoming good information, sometimes we do a muscle biopsy. But in this time and age, because we have so many genetic tests that are really very good and can give us a confirmation of the disease, we hardly have to do a muscle biopsy. But this is sort of like the last resort if the diagnosis is still unclear. So that is the typical visit in the pre-COVID era. But now with COVID-19, we have to weigh certain things. We want to continue care because there's risk for interrupted care, but there's also a risk to face-to-face interaction of acquired and transmitted infection for both the caregivers, the patients, and the healthcare professionals. So in this time and age, telehealth or telemedicine has become a big thing. Especially in our patients with neuromuscular disease in children. This is and has proven now to be a very viable option for a certain subset of patients. Some patients, not all, but certainly a good chunk of patients with muscle diseases, especially kids. This may be critical to continuing care in this time of COVID-19 pandemic, especially for vulnerable populations, but it has its distinct advantages and disadvantages. So what are the benefits? So for the patients and the caregivers and the physicians, there will be a decreased risk of COVID-19 transmission. For patients, they like it because these visits are done in the convenience and comfort and safety of their own homes. So my kids would just wake up 5 minutes before the visit, perhaps, or 10 minutes, and feel rested and are less irritable, less moody, and more likely to participate in a novel kind of interaction, such as a virtual visit or a telemedicine visit. And I find that they like it a lot because it's very novel and exciting and different. And it probably appeals to their digital nature, so to speak. Increased access because many people live far away and it might be difficult to get transportation. I feel that the no-show rates are somewhat better and there's really good patient satisfaction. I'm actually doing right now a survey of patient perspectives of telemedicine in our clinic to see how they perceive it and to see ways in which we can possibly improve it. The disadvantages, of course, will be because it's not a person-to-person interaction. I cannot do a full neurologic exam, but I can still do certain things because in the video, I can ask the patients to stand, to walk, to run, to walk on their toes and their heels, to rise from the floor, making a play sort of this examination. And many times they're very cooperative. I can ask them to smile at me so I cannot look at their facial muscle strength, to blow bubbles, to blow kisses. I may ask them to close their eyes. Many times I will have to ask the parent or the caregiver to assist in doing the exam. And sometimes I just hear their voice, to assess for the volume of the voice, the nasality of the voice. And sometimes I ask them to cough to see the robustness and the strength of the cough. Of course, again, I cannot do reflexes, but there are certain ways in which you can formulate in your mind whether the disease is static or progressive or what the baseline is. Sometimes a disadvantage is that it may delay performance of labs and studies because they cannot go physically to the place where they can do this blood work and these EMGs and NCBs or ultrasounds. There is a need for technological savvy for both the physician and the patients and caregivers. And there's also a need for the availability of gadgets, computers, tablets, phones, Wi-Fi connectivity, reliable connectivity. And this is not ubiquitous because some people may not have adequate access, although many do. So this is a disadvantage for that. And sometimes not all medications, especially controlled medications, can be electronically prescribed. So they have to be written in paper. And because it's not a person-to-person interaction, then that cannot be done in a fluid manner. For instance, last week I just learned I have to have a phone that's better than an iPhone 6 in order to prescribe a controlled substance in my state. So I would have to get an iPhone 7, 8, 9, or 10, and not just an iPhone 6 enabled to prescribe controlled substances. So there are distinct disadvantages and benefits and advantages as well to televisits. But the choice of patients or for televisits are those who are, of course, stable patients. They're patients who are relatively stable and established patients, so you know what their baseline is. And these patients may be the stable patients with Myasthenia Gravis, patients with a genetic and very stable peripheral nerve disease, patients who are on prednisone and steroids and other drugs that suppress their immune system might be best served by a tele or virtual visit because they are at risk for contracting COVID-19 more than the general population who are not on any kind of steroids or any drugs that suppress their immune system. People with difficulty with transportation, people whose caregivers may not be available readily, this might give them more flexibility. Now, a televisit is also can be conducted smoothly if the triage by the nursing staff is also good. Because while the patient is in the virtual waiting room, the nurses can reconcile their medications, they can pre-chart details of the history, the interval history, whether there's they're at baseline, whether there are new problems, how fast these problems are progressing. The review of system forms may already be filled out. That can be rather be cumbersome. And because your time during the televisit is very constricted, 30 minutes, and then sometimes it kicks you off because you have another patient coming at the end of 30 minutes, you need to have all of this in place already so the visit can go fast, smoothly, and can address important topics. Sometimes I ask parents to just go ahead and get the vital signs if they can, like if they have a BP machine, get a blood pressure or heart rate if they can. Also weigh the patient already, and get a height. Have all their medications bottles ready already at their side so that they can easily show it to me and we know the correct formulation, the doses of the medicine, and we don't make any mistakes. I encourage patients to keep a notebook of their questions and to write their questions beforehand and to write the answers to those questions during the visit so that their memory they have some kind of things to jog their memory. And if they can email forms like school forms, advanced directives, test results for review before the visit, and that can be discussed very easily during the visit itself. So telemedicine can be viable and can be very organized and can work very well, especially in those patients that need it and can do it. So in terms of physical occupational speech therapy, I will leave this to the therapists to discuss in a more detailed manner. But generally what I ask myself to do on exam is to have the patients wear shorts or short sleeve skirts so I can see them in a better manner. I get better visibility to look at their muscles. Swallowing assessments can be done by speech therapy, but by a remote video swallow study. Physical therapists can also teach range of motion exercises, passive, active range of motion exercises, instruct parents through the video. And the parents will have to take up this knowledge and do it on a regular daily basis because they cannot go to therapy centers during this COVID-19 pandemic. The downside is that there may be a delay in the delivery or procurement of durable medical equipment because many stores are closed and the processing of this forms for Medicaid and Medicare and all that might be a little bit delayed. So there's a reliance on parents and caregivers to do much of the work of these physical and occupational and speech therapists. Now we know that many muscle disease have concomitant pulmonary issues. So pulmonary function test assessments are vital to follow the course of the disease. In telehealth, we cannot, of course, do the regular pulmonary function testing that we do in the hospital, but we can have a brief or a little bit of an idea about respiratory function by looking at how the patient's breathing, if there's obvious tachypnea or rapid breathing, if there's use of accessory muscles for breathing, then that will tell us that maybe they're not doing quite as well as we want. We can, again, assess the cough to see how easily they can get rid of secretions. Even their ability to converse and talk to you during the visit in a complete sentence can be a good parameter of how stable they are during this course of the disease. So there are ways in which that can also be assessed. Now, there is a very good article and also guidelines that are in the American Association of Neuromuscular and Electrodiagnostic Medicine on performing EMGs and CVs during COVID. This should be elective procedures and can be postponed if they are not. Clinic visits as well. There are some guidelines with that, which I just also alluded to briefly, and telemedicine guidelines. And these guidelines are not just in the ANM website. There's also in the American Academy of Neurology website, the Child Neurology website, the MDA website. So there are many resources available to us. So what are some of the things that we have to think about now that COVID is upon us, and that we just have to live with the challenges of living with a specter of COVID during this time, and especially what are the important considerations in patients with neuromuscular symptoms during this time? You know, there is a known risk of Guillain-Barré syndrome in patients who contract COVID-19. Guillain-Barré syndrome is an acute syndrome or acute illness where the myelin sheet or the fatty covering of your nerves are sloughed off from the nerves. And this is an acute disease that has been associated with COVID-19. In Wuhan, China, where COVID-19, of course, we feel had first emerged, they have a study where showed that up to 77% of patients with COVID-19 had muscle pains or muscle fatigue. And a third of them have increased muscle enzymes. And if you're in the ICU and this very sick COVID-19 patients stay in the ICU for a long time, they can develop this so-called critical illness muscle or nerve disease that's related to their time in the ICU being on a ventilator. So there are ramifications. There are some muscle complications that arise simply by having an infection with COVID-19. Any infection, be it COVID-19 or some other virus or bacterial infection, can worsen neuromuscular disorders. So if you have a COVID-19 infection, it may worsen your myasthenia gravis just as any virus can worsen myasthenia gravis. Patients who have muscle disease, especially those with myasthenia gravis, are susceptible to infections, especially those with spinal muscular atrophy and myasthenia gravis. If they're on ventilators, any patient would be susceptible to infection. There's certain rare esoteric muscle diseases like mitochondrial and lipid muscle diseases that can have increased muscle breakdown when they have an infection. And so their muscles break down or their enzymes go up. And of course, patients with primary heart problems, we call cardiomyopathies, they're at risk for having severe COVID-19 even when they get COVID-19. The course of the disease might be a little bit more severe. COVID-19 may also unmask underlying neuromuscular diseases like chronic, we call this CIDP, or chronic inflammatory demyelinating polyneuropathy, which is like a chronic form of this Guillain-Barré syndrome that I had just alluded to. Patients with neuromuscular disease might also be on prednisone, steroids, immunosuppressives, and immunomodulators. And they are at risk for, they are already immunocompromised. And so we know that COVID-19 affects many times immunocompromised patients more than they do people with normal immunity. So as I said, in New England Journal Medicine, this is a very high impact journal, in June of this year, had looked at the fact that COVID-19 patients can develop Guillain-Barré, and they had 5 patients in northern Italy who developed Guillain-Barré out of about 1,200 patients that were admitted. And 4 of them had nasopharyngeal swabs that were positive for SARS-CoV-2. And 1 have initially negative, but later on develop a positive serologic test for a virus. So there's an association with this nerve problem with COVID-19. Again, patients with muscle disease are at high risk to contract COVID-19 because sometimes there are immunosuppressives like steroids. So you really don't want to go to the hospital if one can help it. So one would consider maybe postponing elective surgeries, postponing going on stronger immunotherapy agents until things sort of like normalize and we have a vaccine. And we have to encourage the use of consistent and stronger PPEs with masks, with shields, etc. And patients need to be vigilantly monitored for this, for any kind of worsening, because that may suggest that COVID-19 has been transmitted. If there is no infection, they might continuing their prednisone and steroids, but there is an infection, one might have to consider tapering off or discontinuing or changing to a less potent drug that suppresses the immune system. So these are things that one will have to think about in this time and age when you have a neuromuscular problem, especially in kids with Duchenne's who are on steroids, prednisone, or the Deflazacort, of thinking about when to start, how to start, and when to taper. So some people, like Duchenne's muscular dystrophy, some patients, they get the newer infusion therapies like eteplirsen or now probably golodirsen, which are infusion therapies for Duchenne's and Becker's, and these are genetic muscle diseases. So instead of going to the hospital, one might think maybe home infusion therapy might be a better option because there's less of transmission. I now give my patients 90-day supplies of medication so that they don't need to go to the pharmacy all the time to get refills. So there's social distancing, and also I encourage mail order, or maybe the pharmacist can just mail order, deliver the medications itself to the home so the patients don't need to go to the pharmacies. Now, it's coming, flu season is coming, fall is coming, winter is coming. We know that best preliminary practice encourages that for most patients with muscle diseases in children and adults, especially myasthenia and CIDP, get the flu vaccine, with exception perhaps of this acute demyelinating disease called Guillain-Barré, because there had been some associations with this disease in people who had flu vaccine. But most people with muscle diseases are encouraged to get the flu vaccine. But if you have a muscle disease and you're on steroids, you might want to avoid live attenuated or weakened vaccines because there are live attenuated vaccines. For instance, while flu vaccine is generally injectable, there's a nasal flu vaccine that is a live attenuated vaccine. So one may choose to give the injectable rather than get the flu vaccine that is nasally sprayed. Now, in COVID-19 vaccine, at this point, just to give you a brief overview, many companies, Moderna, Merck, Pfizer, AstraZeneca, and all these companies are now in a run to develop all the COVID-19 vaccine because the impetus for having such a vaccine is really, really strong and high. And fortunately, the development has been rapid. And right now we are in the so-called final trials, the phase 3 trials, where they now assessing a large number of patients for the safety and efficacy of a COVID-19 vaccine. But when we do have the vaccine, it is possible that if you are on concomitant immunosuppressives like prednisone, cyclosporin, like all these immunosuppressive drugs that we use for muscle disease, they may potentially decrease the efficacy of the COVID-19 vaccine, and we don't know that yet. So other considerations too, if a patient has a muscle disease and contracts COVID-19, as in steroids, as many of our Duchenne's muscular dystrophy kids do, then may need stress doses of steroids for the short period of time in order to prevent their adrenals from failing. And then what we don't know is that we know Guillain-Barré is associated with neuromuscular, with COVID-19. And in the Wuhan study, about 77% had some muscle aches and pain, myalgias and fatigue. We don't know if there will truly be an association with COVID-19 and a possible novel neuromuscular disease or a novel neuromuscular disease, because we know very little yet about COVID-19 and its potential clinical implications. So Remdesivir is what we know. We were all excited because we now have a drug for COVID-19, and this is indicated for severe COVID-19 infection. This was first tried for Ebola, and it is found that it inhibits the SARS-CoV and the MERS-CoV viruses in vivo. The SARS-CoV is the one that caused this severe pneumonia back in 2002 and 2003 in China, in the Guangdong province of China. The MERS was the one in the Middle East and Saudi Arabia that has a high mortality rate, although it's not easily transmissible. And this Remdesivir came out because the New England Journal of Medicine in this, just a few months ago, May, that has found that in a trial, in a double-blind randomized placebo-controlled trial, people who were given Remdesivir versus those who were given a sugar pill did better in general, because they divided this in those who received Remdesivir and those who did not. So the people who received Remdesivir had a shorter time to recovery, and also less people died, 7% versus 11.9%. The side effects were similar in both groups. So Remdesivir seems to be a promising new drug. Not great, but promising. But in the use of Remdesivir, physicians saw that liver enzymes can be elevated, and liver enzymes can be potentially elevated baseline in patients with underlying muscle disease like Duchenne's and Becker's. The liver enzymes can be elevated, so one must be able to tease out what is baseline from the muscle and what is baseline from the use of Remdesivir, if in case Remdesivir has to be used in a patient with a muscle disease and COVID-19 infection. Now, chloroquine and hydrochloroquine are anti-malarials, and traditionally we say that these are contraindicated in patients with myasthenia gravis, because these are one of the drugs that can worsen myasthenia gravis. They also cause a progressive toxic myopathy that may preferentially affect the heart muscles. So it has to be very used with great caution in patients with neuromuscular disease. But again, the efficacy of chloroquine and hydrochloroquine in COVID-19 patients is still rather nebulous, so it's not used routinely. But if and when it has to be used, then one has to be cognizant that it can potentially worsen muscle problems. Many of our patients with neuromuscular disorders are on ventilatory assistive devices, BiPAP. And in BiPAP patients, there is a risk of aerosolization because BiPAP is a very high flow way of non-invasive ventilation. And when this is used, then there's a potential for aerosolation of virus that can affect caregivers and the family members in the home if this is a home ventilator that's being used. Patients on home ventilators will still need periodic visits from physicians and RTs, and this is truncated or made more difficult by COVID-19. There's a lot of talk about proning. This is when people are put in a prone position because it is believed that this makes respirations better for people with COVID-19. But proning in a patient with a muscle problem may be problematic because they can have scoliosis and kyphoscoliosis because of their underlying muscle problem. And because of their underlying problem, there may be a decreased ability to even clear secretions. So aggressive suctioning and respiratory clearance of respiratory secretions can be a problem. In particular, patients with myasthenia gravis and who develop COVID-19 infection, one might have to consider stopping their medicine, which is called Mestinon. The Mestinon is a medicine that is used to increase muscle strength in patients with myasthenia gravis. But if these patients with myasthenia gravis will need to be intubated and put in a ventilator, they will need to get their secretions out through the tube in order to clear the lungs. And if they are on Mestinon, this will increase the secretions more. So it might aggravate or make the problem worse. So people advocate stopping it while the patient is on a ventilator. But it can be resumed if the patient is going to be extubated within the next 24 hours. We also know that patients with myasthenia gravis may have obstructive sleep apnea. There's a high rate. And the maintenance of their CPAP and BiPAP machines may be another concern during this COVID-19 pandemic. Healthcare providers also have to recognize that not all patients with neuromuscular disease who develop respiratory difficulty in this time and age are victims or have COVID-19, because it might be something as simple as asthma. So it might not be, so frightening and alarming. It might be just an asthmatic exacerbation. So a lot of these things should go to the minds of healthcare providers, caregivers as well. Just last week, I had a patient who had generalized myasthenia gravis, a little 10-year-old girl who had exacerbation. And the first thing I thought of, well, we have to test her for COVID-19 because we don't know if this is part of the neuromuscular manifestation. And unfortunately, this was negative. But I have to choose because COVID-19, we know, is associated with strokes. And IVIG, which is the drug that I gave her in order for her to get better because of this new worsening of her myasthenia, has been thought or can cause thrombotic and embolic events in a small percentage of patients. So that has to come into play as well. Fortunately, my patients tolerated it very well and did not have any kind of stroke-like symptoms or anything like that. So the other thing is that during the winter and the fall, there will be a lot of upper respiratory tract infections, bacterial or so. Many times we give azithromycin, which is a macrolide. Now, people with myasthenia gravis can get worse if given this antibiotic, as they would if they were given chloroquine and hydrochloroquine. If they're more severely ill and in the hospital, they may be given a different kind of medication called an aminoglycoside. So generally it's a gentamicin is what they call it. And that aminoglycoside can also worsen myasthenia gravis. So all of this will have to be taken into consideration when picking out the correct medication for somebody with a worsening pulmonary illness and myasthenia gravis. In the unfortunate instance that somebody with a neuromuscular disease, say myasthenia gravis, has to be intubated, anesthesiologists and ICU doctors paralyze a patient before intubating to make it simpler and smoother. So those medicines or agents that they use to paralyze the patients may also exacerbate myasthenia gravis. So they might want to avoid these drugs called rocuronium, vecuronium, pancuronium. There's also a drug called succinylcholine, which is used in possibly intubating patients with pulmonary problems and muscle diseases. But in a certain disease called central myopathy, succinylcholine can precipitate this there's a condition called malignant hyperthermia that can potentially be very serious. So all of these considerations have to be thought of carefully. In this time and age, these are very challenging. Many people have mental health challenges, and maintaining well-being, mental health well-being is paramount. These are uncertain times because there are uncertain times people have difficulty coping and adapting to the uncertainty of the times and the many difficulties that these times are really making us face in many aspects of our lives. Contact with family and friends are diminished. Our children that used to go to classroom in some form of interaction cannot do so. There are unclear directions. When are we going to do the thymectomy? When I'm going to start the steroids? This is the best time. So counseling and maintenance of well-being is important. There are many counseling sessions online, many support groups online, many online yoga exercises, meditation exercises, different kinds of exercises. Accessibility in order to get providers to allay some of these problems are important, and the virtual MDA camp has been done. So planning with advanced directives, emergency care, the threshold for going to the hospital has to be discussed really, really well, because there's a potential that if you go to the hospital, you might be left alone. So this might be important to discuss a priori. So just to very quickly go through these gene therapy things, because genetics is now playing a big part in the diagnosis of muscle disease. And because of this, we have now many gene-based therapies. And I will just talk to you about the 4 drugs, the new drugs that I feel that if you have Duchenne's muscular dystrophy or spinal muscular atrophy, you should be able to ask your provider whether this is a suitable alternative for you. So for Duchenne's muscular dystrophy, we know that this is a problem in the dystrophin gene in this X chromosome. And with you have a bad dystrophin gene, then your muscle membrane is not stabilized, because the dystrophin stabilizes the muscle membrane. And if you don't have that, then your muscle gets weaker. So back in 2016, we now have this drug called eteplirsen, which is FDA approved for certain people with Duchenne muscular dystrophy. This is not for all. It's only about 14% of patients. This is IV therapy weekly, very well tolerated, really, and this only very few side effects. So this is now available at the eteplirsen. And recently in December, 6 months ago, 2019, FDA approved golodirsen, which is Vyondys 53. And I haven't used this yet, but the side effects appear to be very very minimal. And this is another option for those patients who are amenable to this infusion therapy. And there are just many other drugs that are now being studied. One of which is ataluren, which is a stop codon, which acts as a stop codon read-through. And that's something that's already in phase 3 trials. Now, the other drug is the other 3 drugs are for spinal muscular atrophy, which is present in 1 of the 10,000 live births. And it is because you have this gene that is defective, the survival motor neuron gene. But the manifestation of the disease is mitigated if you have a good SNM2 gene. So the drug that we now have is directed towards making a better SM2 protein. And this SM2 protein therapy is called nusinersen or Spinraza. And this is available now as intrathecal, which means it is put into the back to a lumbar puncture procedure. Even having said that, this is still, my patients have tolerated this very well. The only side effect probably I've seen will be headache after the spinal tap procedure, because it's like getting fluid out and pushing fluid into the spinal cavity. There have been rare reports of hydrocephalus. I haven't seen that. And you give it for 4 doses as a loading dose and every 4 months thereafter. So this is the way I've given it. Now, very recently, just this month, there's an oral therapy for spinal muscular atrophy called risdiplam. And again, it increases the functionality of this NM2 protein. And the beauty of this is this is an oral medicine, and you don't have to give it through the spinal fluid space by a lumbar puncture. So this is a very good option for our young patients with spinal muscular dystrophy or atrophy. So the last will be Zolgensma. This is a lentiviral vector gene-related therapy. This is a one-time, once dose. It was approved May 2019 for patients 2 years and younger. Side effect is acute liver injury. So this is another option. In Myasthenia Gravis, which is a problem with the availability and the functioning of this enzyme here that causes communication between the nerve and the muscle to work very well. This is called Myasthenia Gravis, and the receptor is called acetylcholine. And when you have bad acetylcholine or weak acetylcholine, what happens is you have weakness. There's a new drug called Soliris. And I put this in there because 8 and above, you know, a lot of our pediatric patients we follow until 21, 22 years of age. This could be an option for them as well. But the downside is that they have to have a meningococcal vaccine because this is a complement inhibitor. And one has to have meningococcal protection, vaccination to protect them from meningococcal infections prior to getting this therapy. So this is the brief overview of what I feel are the things that one has to know in this time and age regarding the best clinical practices in the care of children with neuromuscular diseases. And these are my references. I feel, these are very good references and they have good websites. And I thank you for giving me the chance to talk to you today and to share some of the information with you. And wear a mask and stay safe. And thank you very much.
Thank you, Dr. Romero. It's crazy how COVID has really changed everything as far as doctor visits and clinical trials and infusions. Are you seeing any decline with patients wanting to participate in clinical trials, or are they nervous about coming to get their treatment that they're already scheduled for?
In terms of patients wanting to get treatment that they were scheduled for, I think the treatments are not that often. Like for Spinraza, it's every 4 months, and Atrophy every week. That's a little bit more often. But a lot of our MDA patients are very well motivated, and we make sure that we have the proper precautions when they come to the hospital, and we assure them that we're doing the best we can to prevent COVID-19 transmission. So I find that many of them are not really discouraged from coming to have their infusions. They still come, and I haven't had anybody contract COVID-19 because they have come for their infusions.
Okay. And as far as telemedicine goes, are we going to be offering that for the near future, for an unknown amount of time? We're just kind of curious about referrals and so forth. I'm assuming telehealth can still do all that for our patients.
I think the COVID-19 pandemic really has changed the medical landscape in many, many ways. And one of the things that we have learned during this pandemic is that telemedicine is really a viable option for a lot of our patients. Certainly for a certain subset of patients, the ones who are stable, the ones who are not immunocompromised, established patients. Certainly for new patients, it might be a little tricky because doing a baseline neurologic examination with good testing of baseline muscle strength, the presence or absence or weakness of reflexes, and all of that is key to establishing a baseline. For new patients, it's really important to do a muscle testing real time and personally to document that. For new patients, it might not be so much of a good option as it would be for those who are stable. But having said that, we have to realize that telemedicine is now something that will never probably go away. Because we have seen the beauty and the usefulness of telemedicine, both from the patient caregiver standpoint as well as a physician standpoint.
And we had a question come in, and I know Dr. Wong has addressed it as well. I just thought I would see if you've actually heard of this or not. Is there any association between autism and congenital muscular dystrophy that you know of?
Autism is a clinical diagnostic criteria, and many patients with congenital myopathies may present with behavioral problems that may mimic autistic behavior. Because, for instance, Duchenne's muscular dystrophy, a small percentage of patients may have underlying developmental delay, and a small a number may have congenital, what we call brain anomalies, neuromigrational defects, and all of that can contribute to cognitive delay, developmental delay that may manifest itself in autistic-like behavior. So it may be its association with certain congenital and genetic myopathies, the behavior itself. But the specific, the autism itself is a very heterogeneous disorder. So, and it can cause by chromosomal anomalies that can cause both autistic behavior, brain anomalies, and muscle disease in some patients. So there is an association, but I don't think there's a causative relationship.
Got it. Thank you. Thank you. Well, thank you very much, Dr. Romero. I don't see any other questions that have come up. So I definitely appreciate your time this morning on a Saturday. And if we do get any other questions, I will definitely send them your way. So thank you very much. And up next.
Thank you so much, Nicole. Bye-bye.
Bye-bye. Up next, we will hear about research updates in neuromuscular care at 10 o'clock. So we'll be right back. Thank you.